So I'm talking about drugs for just a second. I like to use this as a scenario because it's something I feel like applies to you guys fairly often. And it is when you're passing medications, you're typically on a lot of your patients going to start running into situations where you have to give more than one blood pressure medicine at a time. And you got to decide oftentimes like which one you're going to use and why you're going to use it. So this is why I'm so big on the action of your guys' drugs, because if you don't know the action of your drugs, it's a lot harder to understand which drug you're going to get. So that's sometimes why you might run into a situation where a nurse gives two different blood pressure drugs, and then they're calling a doctor later on in the evening or later on in the day saying, hey, my patient's really hypotensive now because I gave his blood pressure medicine. And the doctor's going to ask you, well, which blood pressure medicine did you give and why? All right. My board turned off. So, so let's start back up. Two different blood pressure medicines I like to use. And you guys should be familiar with them because you guys just recently did cardiac stuff. Is a beta blocker. Okay, so beta blockers work in that they are working against, or they're working to decrease your heart rate, right? So the action of a beta blocker is to block the effects. So there's blocking the effects. I'm back. One second while I figure out how to delete. Is blocking the effects of epinephrine, which gets released in your heart, and norepinephrine. There. Okay. So that's blocking the effects of that. By blocking these effects, or blocking the binding sites of where these two drugs work, or where these two, not enzymes, sorry, I'm losing my train of thought. Where these two hormones, there we go, thank you, hormones. Hormones work in your body, it's going to effectively then decrease your heart rate. Okay, so by blocking epinephrine, because we always think epinephrine when we get it like, quick, get the adrenaline, boom. So epinephrine, is increasing heart rate, is increasing the tone of my blood vessels, right? So it's going to cause vasoconstriction. Sorry, my handwriting's terrible. I can read it up. And then, of course, norepinephrine does this specifically, is going to work with vasoconstriction. Okay. So, we always think beta blocker is decreasing your heart rate. So, beta blocker decreases heart rate. But because now we know that it competes for these two binding sites, we know a couple different things. So, one here, beta blockers decrease your heart rate. Okay, number one. By decreasing our heart rate, we are therefore going to also decrease like how fast we move blood out of our heart. Okay, because our cardiac output is heart rate. You guys remember this? Times stroke volume equals cardiac output. Okay. decrease my heart rate, also decrease my stroke volume, decrease my cardiac output. Okay, that's first thing how it works. It also is going to decrease your contractility of your heart. So it's going to decrease the amount of squeeze your heart has. So it's going to decrease contractility. Sorry, I wish I had, I don't know why my PowerPoint won't work on this project, but anyways, so it's going to decrease your contractility of your heart. So decrease contractility is also the same thing as decreasing inotropic effect of your heart. Okay, so it's not able to squeeze as well. So it also is going to be one more thing, and this is maybe not something that they talk about in class, but it also can decrease electrical activity. So this is why, if your patient is in a heart block, especially say like I ran out of room. In a heart block, we don't want to give our patients a beta blocker because of that decreased electrical activity. Okay? So if you're really an AV block, if you're in a AV block, a third-degree block, especially block, please don't give yourself or your patient, not yourself, but don't give your patient a beta blocker. Okay? So contraindicated. And heart blocks. How's that? We got it? Okay. Phew. So that's just one drug. So now real quick, let me go over the second drug I use, which is Previl. Which is the same as saying like okay, so kind of knowing that it's a Previl, what kind of a drug is this? ACE inhibitor. Yeah. So ACE inhibitor. What does this mean? ACE inhibitor means that we are effectively blocking what action? We're blocking the angiotensin converting enzyme, right? So angiotensin, remember we have your renin, sorry, I spelled that wrong, aldosterone. System, right? It's a huge loop. It starts in your kidneys, goes all the way up to your lungs. Just keep going around and around, and helps to increase your blood pressure. And basically, think of this: your heart is a pump, kidneys also are a pump. Your kidneys are basically saying, "Hey, my blood pressure is low. I want something to increase my blood pressure." So it increases by causing the conversion of an angiotensin 1 to angiotensin 2. Okay. So, this is a weak vasopressor, strong vasopressor, okay? So it's creating more resistance within your blood vessels. So what it is doing, go back to my heart drawing here. Okay, so this is your blood vessels, right? Coming out, this is an artery. Okay, sorry, I spelled it wrong. it is increasing the resistance here. So it is increasing your systemic vascular resistance, or increasing your after load of your heart. That your heart has to overcome. So now that I've increased my afterload of my heart, I start having higher blood pressure, right? Because narrowing my arteries down, my heart has to push harder, so it has to beat harder, okay? So it's push more, harder and harder, okay? So that's how ACE inhibitors work. So therefore, ACE inhibitor is going to work right here. Typically, it's going to work right in your blood vessels by decreasing the resistance that your heart has to overcome to move blood forward. Okay? So, great things about ACE inhibitors. ACE inhibitors do not ACE inhibitors do not decrease cardiac output. Actually help increase. They help increase cardiac output because they are decreasing your SVR. Okay? Helping your heart become more efficient, better pump. So they also do not have an effect on your heart rate. Okay? So no effect on heart rate. It is strictly within your vascular system. Okay? So now knowing that, here's your patient scenario. Sorry, I'm running out of time. Okay, you have a patient. You're about to pass your 9 o'clock medicines, and you're going, you do your vital signs, and your heart rate is 63. Your blood pressure is, let's say, 115 over 60. Okay, this one here. And your output for the last 4 hours is 200, which is approximately, we'll just say, 50 milliliters an hour. Yeah, or take. You know, maybe an hour. Maybe one of those hours was like 10. But overall, for the last 4 hours, it's been 50 milliliters. Now, here's your medications. You're going to give metoprolol, and you can give Fernavil, You also have there's going to make it more harder for you guys. You have a potassium tablet you got to get, as well as a Lasix. Alright, bring it hard. Okay. Of these drugs, which one are you not going to get? Remember, this is a beta blocker. This is a ACE. This decreases heart rate, decreases cardiac output. This decreases SVR, increases cardiac output. Something else an ACE does, you should probably be aware of. An ACE has effect So, okay, so I was going to give him drug I would not give, based on my vital signs, is metoprolol. Reason is because of the fact that metoprolol is with this heart rate and this blood pressure and this urine output. And if this is, say, 9 o'clock in the evening, I'm not going to give it because what happens to your body at night when you go to sleep? Right, start slowing heart rate down, right? Heart rate slows down. So, nighttime, you have lower heart rate, which equals what? Lower blood pressure, which is going to equal lower urine output. Okay, so I'm not going to give the beta blocker, but I will give my ACE inhibitor. And I'm going to go ahead and give my potassium because of the fact that Lasix is a loop diuretic. Which works on the ACE immune independent. Which, remember from way back in AMP, the ACE immune loop of Henle is where primarily most of your magnesium and potassium are absorbed. So, we'll go ahead and give both those. Even though Prenavil causes a little bit of potassium sparing. Not sparing diuretic, but like, you can hold a little more potassium with your Prenavil. So, but for my rationale is because my heart rate is 63. I know that a beta blocker is going to decrease my heart rate even more than 63. I also know playing, blah, 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 blah. I also know that my heart rate is going to decrease at night because it is a natural occurrence that your body is going to slow its heart rate down, right? Sympathetic nervous system is going to slow down, parasympathetic nervous system is slow down, everything slows down at night. So I know that my patient awake and has probably had his, both metoprolol and his Prenavil during the day and his Lasix during the day. I know that he's probably, this is him medicated up. But because my urine output is marginal, 50s, yeah, it's okay. Oh, he only needs to be 30 milliliters an hour, right? However, if I decrease my heart rate, I'm going to decrease my cardiac output, which is going to decrease my urine output. Okay. So, all I really want to do is just maintain and make sure I have good blood pressure. I'm going to give a Prenavil because that's going to have the least overall effect on these three things. So that is my rationale as a nurse thinking through it. Now, obviously, situation is going to occur, where maybe this is, a heart rate of 80, still blood pressure of 115. In that case, maybe I'd go ahead and give them both. But in this case, heart rate of 63, blood pressure of 115, I'm going to give them a Prenavil, hold my blood pressure, or my metoprolol. So, make sense? Cool. Cool beans. Okay.